apologies. I've got one apology from for Laura Sharp, CEO of the GP Confederation. I haven't heard any more. I don't know if Peter, have you got any others that's come in?
I have no other apologies, Chair.
Sorry?
I have no other apologies.
Oh, okay, fine. So let's quickly move on to the minutes. Obviously in the paper, just to papers to see from page 2 onwards. Does anybody have any corrections or queries about that, or anything matter arising they want to bring specifically related to the minutes? Otherwise,
yes, please. So I'm Lorraine Sunduza, Chief Nurse for Elft. I was at the last meeting, but I'm not recorded in the meeting minutes. I'm representing Navina Evans.
thank you. Is that Peter to correct? Thank you very much. Otherwise, we're happy with those. Good. Right, just before we move on to the sort of action track and the substantial items of the agenda, I just want to have a pause for a moment for us all to reflect whether we have any particular conflicts of interest that we need to bring to the attention of one another on this agenda, or want to bring on, we should always feel open to actually mention them on behalf of other people if they haven't thought about it. And of course, mention them as we go along if you suddenly think of it. Okay, let's move on then. Actually, I've got one little comment in the chat. I'll just check that's not in relation. No, it's not. That's in relation to your comment, Lorraine. So we have an action tracker. The 4 items on it, 2 of them are complete. One, the first and third being complete. Well, the third is actually on the agenda today, but the item is complete in that sense. Number 2 is in action, and we'll be coming back to the November board. And the 4th, which is tracking health inequalities through a joint health and wellbeing strategy, is in action and was due for an update today's meeting. Sandra, I think I've got your name next to it for an update to the board on that item.
We have an oral update. It's on the agenda.
You'll cover it there. Fine. Okay. Thanks very much. So let's move on from that. In fact,
sorry, Chair. I put a question in the chat. I should have raised my hand. Just between the minutes and the action tracker, I'm conscious I was in the chair around the community voice item last time. How we're sort of tracking, taking forward what I think was a wish to continue that engagement on carers and policy around it. There's a tricky thing, I think, for a board like this, and especially around the community voices item, about whether it's kind of an action for the board or where it's an action that someone on the board is sort of taking away, as I think Councillor Kennedy suggested we sort of would, to have that sort of separate meeting with perhaps Health Watch and that carers group, and maybe there's some way in the action tracker kind of separating those 2 things out, because we shouldn't have to do everything through the board if there's a sort of route, but equally we do need to make sure that something like that does happen, if that makes sense.
Yeah, I've just added a quick update actually on a meeting I had with Cathy Lovelock, just to talk through some further actions.
Okay, I'm not sure how we'll settle that there now, but we need to discuss that maybe outside the meeting, how we reflect what you just said, Philip. Okay, let's move on then. So, in fact, the next item is back with you, Sandra, for a quick 5-minute verbal update on the C19 response.
Thank you, Chair. For those of you who've heard me say this several times today already, I apologise. And for those of you who are hearing it for the first time, I apologise for not showing the slides for the 4th time. So this is literally just going to be a quick oral update on where we are in terms of the local outbreak and the work that we're doing in our response to the outbreak locally and to the pandemic more generally. So we've had an ongoing outbreak in Hackney, as you know. It was mainly focused in 3 wards in the north of the borough, where we focused most of our attention and have been working with the community in that area, and our incident management team has been focused all around that. And there's ongoing work to do there, but it appears to be stabilising, as in not continuing to shoot up, although at the same time not necessarily declining quite as we might have hoped. But there's also been a general increase in cases in young people, young adults, in various different places all across Hackney, as there has been in other boroughs in London and in fact across the country. They're not necessarily connected at all to the outbreak that we've been dealing with in North Hackney. So that's done 2 things. There are 2 things. One is that our general incidence of cases, as in the number of cases per week per 100,000 population, is somewhat lower in the last 7 days than it has been for the previous, not just the previous 7, but even the previous several weeks. Some of that is very likely related to people not testing as much as they either want to, or because there's been difficulty getting access to testing, and some people maybe not as much as they should be for various other reasons. And some of it may genuinely be that there's been some reduction in the infection rate in the borough, and we can't really know that until we see the testing rates going up again. At the same time, other parts of London, particularly other boroughs around us in northeast London, have seen their infection rates go up, and so we're actually joining together to work together on how we can coordinate our response to this more general, widespread increase in cases that we're seeing. In addition to the sort of specific outbreak control work around the increase in cases that we're seeing now, we've updated our local outbreak control plan. We've continued to develop the standard operating procedures that support that, most of which have been, there are going to be 16 altogether. We've already published 13 of those, and there's just 3 more to be signed off and published, and communicated with the relevant people who run or manage the relevant settings that they refer to. We're also getting into the next phase of our work is developing a local contact tracing system, where we are getting some local council staff trained to use the national contact tracing system, trained in both the work of contact tracing, using the web tool, and then all the other relevant safeguarding, information governance bits that they need to know, as well as being trained in making every contact count, and working with the public health team so they can basically make up the shortfall that's happening with the national contact tracing system. So all the people that the cases that they are failing to contact at the moment, we will get the data about those, and we'll be following those up locally. And where that's been happening in other parts of the country, like in Peterborough or Blackburn with Darwin, for instance, they've managed to close the gap from only following up, say, 75% of cases to reaching over 90% of them. And that's a really important thing, is not just to reach the cases, but to reach them really quickly. So we'll be getting the data 24 hours after test and trace has had it, and then we'll follow people up. And we're hoping to complete all the preparatory work over the course of the next week and go live in the following week.
Great, thank you very much, Sandra. I can't see any questions about that per se. I think that was a very helpful update. I know that quite a lot of people who might have questioned you have already questioned you, particularly during the course of today, about further details. Okay, well, I think we should let that sit. Thank you very much for that, and move on. So, John, can I turn to you, John Williams, to introduce the community voice section? We have a 15-minute piece from you and your colleagues. Thank you very much.
Okay, thank you, Mark. I'll do this quickly. So I've introduced John Thornton and Malcolm Alexander, who are going to speak on transport issues in the borough. John's going to be focusing on the kind of the community aspect of it and how things work out in the kind of the outside world. And Malcolm will focus on patient transport. I'll hand across to John Thornton first.
Hello. Yeah, can you hear me okay?
Yeah, fine. Thank you.
Good. Hi. Yeah, John Thornton, and I'm from Hackney Disability Backup, and also been a member of Health Watch many years. And I'm basically going to be addressing the issues which have been raised with members and other disabled people who talk to me about what's been concerning them in the borough, both on long term and also recently. Just regarding transport strategy, people are probably aware that transport strategies can adopt, certain different policies. One of them is tackling inequalities through the adoption and implementation of a hierarchy of needs, where the disabled pedestrians and children come at the top and private motorists come at the bottom. And the argument that many people and myself would have is that the transport strategy in Hackney fails to adopt that hierarchy of needs. I'm just going to cover taxis, buses, trains, walking and freedom passes quickly. So regarding taxis, it's great there's been recently with the COVID issue that there's been greater flexibility by Hackney Council. It's allowed us to have our carers to use the taxi card rather than us having to actually leave the house to get things that we need. But one of the issues which nearly everyone complains about is that no taxis are available when people actually call. So it's almost as if we were sitting there with a useless card. People have raised regarding taxis that due to the new cycle lanes, I think in Green Lanes and Queensbridge Road, these light segregated cycleways, that people who travel by taxi would be unable to access their homes and also healthcare facilities in those two streets. So that really does need looking at. The other thing is regarding LTN zones, that taxi drivers are getting lost and there's an utter lack of signage, particularly around, I think, Nile Street, Proper Street, on member complaints of. Regarding buses, there's talk of having 50% fewer buses available for disabled people to catch, particularly during the school hours. And members have raised concerns regarding the difficulty of queuing for buses and also, having to stand for twice as long waiting for one to come. And the issue still comes up regarding bus bypasses, and that these are totally unsuitable for disabled people. And the research has shown this again and again. Hackney members have actually been involved in the research on it, and they deny disabled people the right to be able to access a bus stop. Trains, despite assurances from the London Mayor and Transport for London, staff have been removed from the booking offices in our Hackney stations. And so there have been complaints that there have been nobody available for passengers who've required assistance, particularly for transfers and for doing transits. Walking. A few years ago, we did the Getting There report, which presented at full council, where we indicate that over 90% of all disabled residents in Hackney, 91%, had a fear of leaving the house. In particular, they had a fear of going into the parks because of cyclists and fear of being on the footway, again, because of cyclists. And that I think the number is even higher with the older people's group. So footways still need to be tackled. It's got worse because of the rental bikes, which are now being dumped on the footway, with no sanctions for the companies who allow this to happen. And also recently complaints regarding traders and restaurants causing obstructions on the footway, and that this is not, these issues are not being enforced. Walking is good for physical health, it's good for mental health. I think it should be absolutely essential that walking is #1 priority in the transport strategy in cycling, rather than just cycling. Regarding Freedom Pass, the qualifying conditions have been set by the government, but there is an opportunity for local councils to be flexible on that. With the COVID and there's so many people suffering from pulmonary and breathing difficulties, it looks like there's going to be a lot of new people who are actually going to be requiring a Freedom Pass who've not required one in the past. And I'm wondering to what extent the council is preparing for the sort of onslaught of new applicants who will be entitled to one. And also the same applies for taxi cards. In addition to that, transport strategy, I think, has got to take into account that, you know, more people, particularly more young people, are going to have difficulty walking, and they're going to require more seating in the street.
You're on mute, Mark.
We've lost John.
Yeah, no, clearly.
Well, let's see if he can reconnect, or have you got the rest of his, what he's going to say, or should we turn to Malcolm?
I think turn to Malcolm, and I'll try and connect with John and see if he can get back in.
Okay, Malcolm. I see you in the chat. You thought you were joined by a different system. I can see you. Can't quite hear you yet. I recognise the smile.
Okay, John Thornton's trying to return, actually.
And Malcolm, you're still got a mute sign next to your name, so we can't hear you. So, John, we have another sort of 10 minutes really. So just I'll extend obviously to that length, but
yeah. Let's see. So Malcolm's trying to join, and I think John's back. So yeah, John, do you just want to continue?
Could I just mention one other thing, which was a letter that was sent out on July 27th by Tim Shields and David Mayer. And on July 27th, saying that we're pleased that the easing of restrictions will mean many clinically extremely vulnerable residents will be able to safely visit friends and family after a challenging period of self-isolation. And on July 27th, UK, I think, was second highest in the world with COVID. London was the highest. Hackney was the highest within London. And I think it really was irresponsible to have that letter sent out to one of the most vulnerable people in Hackney, saying that it was safe to go out into the streets again.
okay,
anyway,
thanks.
A lot of us are very tight, and I've been fighting this for 25 years for equality for transport here in Hackney. A lot of us got burnout. We need funded organisations such as Hackney Health Watch and other organisations to work on our behalf to ensure that we do have equality of opportunity for travelling in Hackney. Thank you for listening.
Thank you, John. And of course, later in the agenda, we do have another substantial item on the transport policy. So value you being on that part of this meeting as well.
Yep.
Malcolm doesn't look like he's making progress there. Looking at what I can see. John, did you want to bring to our attention some of the things Malcolm wanted to say?
Yeah, it's probably better than Malcolm does. There was a paper circulated.
Actually, before we do, sorry, John, just 1 second. Did anybody want to comment? Sorry, I should say in terms of what John's been saying before we move on, because Malcolm, I think, is obviously talking to us in a slightly different piece. Philip, I think you've got. Do you want to make a point of clarification?
Yeah, thank you, Chair,
and thank you as well.
Thank you, Chair, and thank you, John, for your comments. I just wanted to pick up the point about the letter. I was unclear who'd sent the letter and the instructions and the context. And obviously, while I don't know whether Sandra would want to sort of come back on the figures, but my reading is while Hackney has had higher incidence of coronavirus circulation and positive testing results than other parts of London at certain points in the last 2 months. London hasn't been the sort of the hotspot of any build up towards second wave, second peak. It's been sort of places outside of London. So, but I didn't catch who'd sent you the letter or who'd sent members the letter and that context. And
the letter was sent by Tim. It was a joint letter by Tim Shields and David Mayer. From Chief Executive of Hackney and also Managing Director of City and Hackney Clinical Commissioning Group. And the day in question, July 27th, was I think the incidence of the highest deaths in the borough, the highest deaths in the UK, and many of our members have died of COVID. So it's a particularly painful issue for many of us.
Sure. Did you want to come in with a comment?
Oh, just a quick comment, just to thank John for his contributions and making a valuable point about people cycling on the pavements and how problematic that can be. And if we're going to encourage active travel and people walking and all the issues we have now, especially around social distancing, it's how we get that messaging across really about shared space and respecting everybody using the shared space. But it was just a valid point, and thank you, John.
Thank you.
I've got Caroline Selman. I should say I can't see everybody on the call. I can only see 16 people. So if I don't see a hand go up, it's because you're not in front of me. Just put a note in the chat. It's Caroline Selman.
It was just to briefly note, conscious that Councillor Burke isn't here, who's the lead for road safety. I do understand that he's due to catch up with the officer who was leading on the Ageing Well strategy, round about talking through, having picked up through that route as well, similar concerns about shared use of pavements and bikes on pavements. I also know you mentioned round about dockless bikes being left. I also know that there was a recent paper that was brought and adopted at, I think, Cabinet, which was linked to the accompanying enforcement plan locally in terms of dealing with bikes that were left abandoned and creating hazards round about as well. So I'm not the closest Cabinet member to that because, like I say, I'm not the transport lead. I am aware that the transport lead, Mr. Burke, is aware of those concerns and picking them up with officers and the Ageing Well strategy.
Thank you. Sandra, then Chris. John, I'm mindful that we were using most of our time up on this one item. I still see that Malcolm's struggling to get in. So we might need to bring him back another time.
Okay. Thank you. I just wanted to clarify the point. I didn't see the letter that you're referring to, but I just wanted to address that point about people feeling still very nervous about going out and saying this letter arrived, and while this on the news there was this peak of deaths on that reported on that day, and I just want to clarify something for people so they get to understand. So the Mayor is absolutely right that even though right at the beginning of the pandemic, way back in early March, we had the highest incidence of cases in London. Actually, they're relatively low compared to where it's really taken off in other places in the country and in the world. But in July, when you're talking about, we had low incidence of cases in London in general, and even though it had taken off in Hackney at the end of July, we still weren't talking about anything like, and still aren't talking about anything like the peak of the pandemic in March and early April. And also, just to be clear about the fact that going out on the street is not really what's the risk for people. Your risk of getting infected outdoors in the open air with coronavirus is really quite small. You're much more likely to get infected in an enclosed space, which is very likely to be your own home. A lot of the transmission is happening in people's homes. So what we're trying to get people to understand about physical distancing and hygiene is that you need to keep enough apart from other people and practice all those measures so that you reduce your risk of infection. But the fact that something happens to get reported on a particular day doesn't increase your personal risk.
Okay, thank you, Sandra. I've got Christopher. Christopher, you want to make a comment?
Thanks. Yes, very quickly to pick up on the point about adequate resting places and places to sit. Very well made. Has been raised in our draft Aging Well strategy that is going out to public consultation soon. Very much encourage you, John, and all your members to feedback on that and encourage that in that strategy we talk about adequate and frequent stopping places where people can rest. Thank you.
Okay, as I say, Malcolm, I'm sorry we've had to use the time up. Well, we've used the time up profitably with this discussion, but I think we'll need to bring you back another time unless we can find a way to get you into the meeting later on. But John, do you want to just say what you put into the chat out loud, John Williams?
Yeah, I was just picking up on what John was saying about how Healthwatch could help here. I mean, we'd be happy to kind of speak with John further about the issues he's raised, and then take them forward with the council transport lead and make sure that the strategy kind of reflects what disabled people want.
Great, thank you, John. And well, thank you, Johns. Actually, I must say, and this isn't in any way it's a flippant comment, but I absolutely agree with you, John. The worry about walking through parks when people are cycling up behind you on the paths, they shouldn't be doing it. But whatever happened to people having a bell on their bike? I've never been rung walking in that situation. I might get shouted at. It seems extraordinary. Anyway, showing my age perhaps. I think we need to move on now. So thank you very much all. Apologies to Malcolm. We'll give you another chance if you can today, if not on another occasion. So moving on to the item 8, Health in All Policies Forward Plan. Donna Doherty-Kelly, I think you're going to introduce this, aren't you, Donna?
Yep.
And actually we are looking to, are we looking to endorse? We are, this plan and the forward plan you're presenting as well. And agree some key lines of inquiry, which of course there are some very good ones in the transport policy paper, which follows a couple of agenda items up. So it might be worth referencing that as we go along.
Thank you, Chair. So I'm just going to quickly outline the forward plan, the proposed forward plan and key lines of inquiry for the proposed board's adoption, and that's to do with taking a whole health and all policies approach this year. So just to recap for anybody who hasn't been at the July meeting, a paper was brought around addressing the wider determinants of health within the Health and Wellbeing Board, and the board agreed to use the Health and Wellbeing Board forward plan as a framework for action to review wider partner policies and strategies. And that's really to ensure that social, economic and cultural factors that influence health are systematically considered within all relevant policy and strategy development. So what we've tried to do is outline some key wider determinants of health and the rationale behind those, and tie those in with future Health and Wellbeing Board dates. So if you have the paper in front of you, this is outlined on the second page of the paper. And what I've tried to do as well is map some example strategy and policies that the board could potentially review under that wider determinant. And that's to be discussed. That's just proposed strategies and policies. We might have other ones that you might want to consider in those board meetings. That was really just to get us started. So we've broken that down into education and skills, built a natural environment, good work, housing, communities and social connection, and that takes us up to September 2021. So we haven't gone any further than that, but obviously this is flexible and we might want to consider other areas as well. And then thinking about those meetings and how we sort of take this work forward, we have outlined on the third, so the bottom of the second page and the third page, some key lines of inquiry we might want to think about when we're looking at those strategies under the wider determinants. So those are 8 proposed key lines of inquiry, and they could be shaped and modified as we go forward, but we just thought this might be a good starting point. And as Dr. Ricketts already said, we are going to try this out with the transport strategy today, so it might be a good time to reflect at the end of the meeting on how that's gone, or you might have some other ideas of other key lines of inquiry that we might want to think about. So we're bringing this back, and we are hoping that the board will endorse the forward plan and agree to consider key lines of inquiry in advance of Health and Wellbeing Board meetings to prepare for the policy review within the meeting. And then if the work does progress, we would hope that the board could review and update that forward plan on an annual basis as well. So I'll stop there, I think.
Thank you very much, Donna. Let's have a look for hands and comments. Caroline Selman.
Hi, thanks, Donna. So noted that this isn't meant to be an exhaustive list of the policies, but just on particularly the themes, just checking if the intent was to also include one on community safety, just because that's one of the determinants. And I assume, well, there's 2022, I think, is when it next comes up for review, but we do this few months look at things like the Community Safety Partnership Plan and some of the sub-plans underneath that, such as their violence against women and girls strategy. And then the other was just to understand what the mechanism would be for us to, I guess, identify which policies we were looking at across the country. Just where the council's huge and there's lots of policies being adopted all the time, and it was just to get a sense, I guess, of the mechanics of how we would kind of drastically kind of check we were picking up on the policies we wanted to pick up on.
Yeah, that's a really good point. I'll definitely include community safety. I guess we only went so far with this forward plan, and you could go on for years and years. So I'll definitely pick up on that. And then on the mechanisms, I guess we would want to look at the ones we can influence possibly the most, and we would also want to have a think about the health impacts of that strategy or policy. And I guess a sensible approach would be look at the strategies and policies that are coming up for renewal, so that we can get in on time before that strategy or policy is refreshed or developed. That would be my thinking on the approach, but there might be other suggestions as well.
Great, thank you. I'm going to go to Councillor Carol Williams and then Councillor Christopher Kennedy.
It was just a quick note and point of information more than anything else, just so you were under the education and skills, you've got Hackney's highest rate of working age. So adult learning and skills you've got under education, but that sits in employment and skills in the adult newly integrated adult learning service, and that's something that we've just done. So it is separate from education, but may not have much of a bearing on the document itself. Just thought you might want to be aware in terms of when you do get reports to the board.
Thanks for that.
Christopher.
Thank you. in terms of making sure that health impacts are considered absolutely every time, I wondered if there was scope for our policy template to actually, in the same way that we have an equalities impact assessment for everything we do, a health impact assessment. Is there a way of bolting it on to make sure everybody always does it?
I think that's a great idea. I guess it would. I'm not sure how we would go about that in terms of doing it, but it's. I mean, I think it's a great idea. I don't know if other board members are in agreement.
I certainly would be. Yeah, Glanville.
Thanks, Chair. And just, I didn't know that comment was obviously coming up, but I think there's some value in it. I think it's just where there's so many parts of the health system that could be commenting. And at the moment, I think we would need to work out who was responding kind of to that and writing those comments, because it's very easy to understand if it's the legal section of a cabinet report, because it's going to legal. But while we have a public health team, we also have the adults commissioning kind of work that then links into the ICB and just how those things would fit together. But I think having that sort of opportunity to feed in would be really useful. And I guess we could make it clear that it's about implications for public health, perhaps, or something more focused. I just wanted to come in on housing. I really welcome that section. And the links that we're trying to think about building, perhaps through the Health and Wellbeing Board. There has been some really good kind of work between public health and private sector housing before. There's clearly commissioning work that happens in adults around housing that directly supports people with poor health and vulnerability. It's just how we sort of hold that in that item and ensure that we're doing the things that we need to. The other thing I think about having something strategic here at the Health and Wellbeing Board is too many times we appear to be discussing kind of rough sleeping, health and homelessness at the ICB. We're then discussing it kind of here. We'll discuss it somewhere else. One of the few places we all come together, especially in the context of determinants, is this board. And it would be good to get some preeminence, I think, and recognition here. And my first board I chaired, we had the Musa case around the gentleman that died on our streets who was a rough sleeper, and Dr. Addy Cooper was talking about an investigation the Adult Safeguarding Board was going to do into that and the implications. It is a good place to kind of take, you know, that obviously the two safeguarding boards sit on the Health and Wellbeing Board. I'm just thinking it's a good place to bring it all together and think about that.
Mm-hmm. Fine. Sandra, I've got your comment who would come in.
Yeah, thanks. Just in terms of making a clarification about the health impact assessment, for those people who don't really know what that is, that it is about the public health implications really, rather than implications, not specifically implications for healthcare of a policy. So it's much more aligned to something like an equalities impact assessment or an environmental impact assessment, and trying to understand what the health impacts, both positive and negative, are of the policy as it's first described, and trying to seek ways to build on and improve the positive impacts and mitigate the negative impacts. So that's what a health impact assessment, I mean, to do a full health impact assessment is actually often a really major undertaking, especially on a big policy. But in terms of having a kind of rapid desktop type framework that people could use, but that didn't become a very reductive tick box exercise, that could be something that could be built in if there was if this board agreed it, and if we went through the appropriate governance processes to make sure that that was embedded in the process for the board.
Okay, yeah, thank you, Sandra. I'm aware that we also, Donna wants to make some comments we have indirectly about the key lines of inquiry, and I think those that are stated there are a very good place to start from. We'll explore them in a bit more detail as to how they apply to transport policy down the line, but I think that's a we'll refine them when we know whether they do what we want them to do.
Yeah, that's perfect.
So I propose that we move on then. Are we happy as a board to endorse the forward plan, bearing in mind it is not set in stone, and if things come up which we feel we need to do, we can change things as we go along. But as it stands at the moment, I think this is a very reasonable forward plan.
Agreed.
And we'll work with the key lines of inquiry as stated there, and we'll review it at least on an annual basis, and then, as I say, intermittently if we need to be. Okay, thank you very much, everyone. Shall we move on? Donna, you're on again for the proposed membership paper, item 9. Starts on page 29. Again, we're asked to nominate new members that provide expertise and strategic influence. Philip, you're going to be asked to invite those nominees onto the board.
I think just before we do that, Sandra's going to give a quick update on health inequalities work, and I'll give an update on health and wellbeing strategy, and then we'll move on to the proposed membership, if that's okay.
Okay, that's fine. I thought it was the other way around. Apologies.
Okay. So in terms of the health inequalities, just to recap, at July's Health and Wellbeing Board meeting, members agreed to adopt a population health framework to guide our local action to tackle health inequalities, and to use this framework to develop the new or refreshed joint health and wellbeing strategy, which will refocus its work on tackling the wider determinants of health, the social, economic and environmental determinants of health through a health in all policies approach. And members also agreed to establishing a working group to develop the new strategy. So since then, the work that's happened is that there's been quite a bit of work to support the health and care system to address health inequalities in developing their recovery plans, including developing a toolkit to support planning with an inequalities matrix, and associated with that, a rapid equalities impact assessment checklist, so a little bit like what I was just describing for the health inequalities health impact assessment framework. And they're also in the process of facilitating sessions with different integrated commissioning work streams, the Primary Care Enabler Board, and hopefully also the Mental Health Coordinating Committee, to put these tools into action. And some very concrete plans have emerged from the initial session with the planned care work stream using this toolkit. And the CCG Equalities and Diversity Group has been tasked with reviewing existing equalities impact assessment tools with the aim of refreshing the supporting guidance and training to ensure they're fit for purpose. We've also started to do some groundwork to inform the future health and wellbeing strategy, learning from this by drafting an initial high-level health inequalities plan, setting out the actions needed across the local system to prevent and mitigate inequalities associated with the direct health impacts of the pandemic, and to prevent and mitigate health inequalities associated with the indirect health impacts of the pandemic response. And that's where we are at the moment. Clearly the strategy is going to look beyond COVID as well, and not just be looking at the not just looking at things through a COVID lens, but it's actually been a really helpful way of focusing people's attention. And then the next steps are that there's some work already underway to establish a multidisciplinary health impact, health inequalities steering group to provide a focus for this work. Excuse me. To ensure our collective efforts have maximum impact, and among other things, it's anticipated that this group will produce further recommendations for consideration by the board for inclusion in the strategy, as in beyond the COVID impacts. And members of this steering group will work closely with the Health and Wellbeing Board Strategy Working Group, probably with a bit of overlapping membership, so that we have a coherent and consistent approach to health inequalities. That's it from me. Thank you.
Thank you, Sandra. Donna, back to you.
You're muted, Donna.
Thanks, Sandra. Just following on from what Sandra said as well, it's just a quick update on the proposed membership of the strategy working group. So the aim is to have representation across all 4 pillars of the population health system. So the proposal for the working group would be Councillor Kennedy as chair, Anna Garner from the CCG to represent integrated health and care system pillar, Jake Ferguson or Tony Wong from HCVS for places and communities pillar, Sonia Khan, head of policy and strategic delivery, or somebody from her team to represent wider determinants or the places and communities pillar, myself for health behaviours pillar and programme management support, Jane from the public health team for representation of population health and also as inequalities operational lead, somebody from the public health intelligence team, possibly Diana for data and intelligence support, and Jamal Wallace from the IC Comms and Engagement Enabler Group lead as well for comms and co-production support. So that's the proposed membership, and that's sort of where we've got to in terms of joint health and wellbeing strategy update. And I'm now going to move on to the proposed membership, if that's all right.
Yep, I haven't got any hands or any comments, so carry on.
Great. So there is a paper attached to this in the pack, and just to recap, the Health and Wellbeing Board agreed to update the board's current membership in the last meeting in July to ensure representation from partners who can make the greatest contribution to reducing health inequalities. So the paper in the agenda pack outlines a proposal for the extended membership of the Health and Wellbeing Board. So that's the background and the context, and on page 2 of that paper we have set out the proposal for the expanded membership and included examples of proposed members and identification of the areas of the determinants of health that the members would represent. So I hope that's clear in table 1 if you're looking at the paper. And it's proposed that we look for representation across education, the built environment, income and employment, community safety and housing, so at least having a nominated member to represent each determinant. And if you look at the table, what we've tried to do is take proposed services and or departments that we identified through the consideration of their contribution to the work within that identified wider determinant theme. So we've got education, environment, income and employment, community safety and housing on one side, and then the services and organisations that represent. So we have outlined possibly children and families department, education and skills department, and maybe thinking about proposed representative there as the director of education, thinking about environment, the planning department, transport department, primary care network representation, and then other proposed representatives might be the director for neighbourhoods and housing, possibly London Fire Brigade. Moving on to income and employment, we thought the service or department that would represent that would be the economic development department. And we thought here we might have council representation for employment, skills and human resources, possibly the director of strategy, policy and economic development, and a representative that has poverty included in their portfolio. Moving on to community safety, we thought that might be the borough commander, and again another representative who has violence reduction in their portfolio. And finally, for housing, we thought again a proposed representative might be the director of neighbourhoods and housing. So that's for discussion, obviously, and we are hoping that the board will be able to ask to nominate new members that provide expertise and strategic influence over those wider determinants of health, and the representatives are invited onto the board. And I'll finish there.
Thank you, Donna. I've got, I can see David Mayer's hand up.
Thanks, Mark. Thank you, Donna. So just to be clear, I guess the paper title, this is about expanded membership rather than new membership. So it doesn't obviously include existing members.
Yeah.
And I guess it would be helpful that, well, the mapping of what is happening where in terms of wider regeneration, community safety, policy development. I guess we just need to be clear about the purpose of this group and its role in shaping that, as opposed to some of the other strategic groups, the Community Safety Partnership Board. There's a number of other fora where some of these kind of discussions. I just think there's a bit of internal hygiene across us as partners, really, just so that we're crystal clear about where policy is being developed and who's responsible for driving it, and we don't kind of fall over each other with different meetings doing comparable stuff.
Thanks, Philip. David, over to you, Philip.
Thanks, Chair. I think we've obviously looked, some of us have looked at this sort of list before, and I think it's going to be a bit iterative. I think this is a good sort of capturing of where we are and where we're heading kind of on the agenda. I think I did, when we pre-met, Chair, think about is the representative in the health system correct on the Health and Wellbeing Board? And this is clearly reflects a kind of relatively internal council review of who's contributing to this agenda. And as both the sort of health system goes through its changes over the next couple of months, and notwithstanding the new subboard that Donna was reading out, that I think captures some of that change in focus. I don't want to just sort of add more and more council people to this and dilute the sense it's a partnership, but I do think the people named here are really important. Sorry, the roles here that are named are really important to taking the agenda forward. And I think what Anne has just put in the chat that she may want to come in on is also important. Just for points of clarification in the minutes, Director of Education is correct, but it's Group Director for Neighbourhoods and Housing, and Cabinet Member for Employment Skills and Human Resources. And then there's obviously a bit of an alert to a restructure within the council around this. But I think what we do want to do is get as much of this sort of agreed here, so it can go to full council in October, which allows us to do the appointments formally onto the Health and Wellbeing Board. The next opportunity to do that, I think, is January.
Okay. I've got Anne, did you want to say anything? And then I'll bring in Sandra. Thank you for the comment about, because I was worrying about the balance of health in this, and I pre-maybe about that. I know you mentioned and clinical directors, but it was in part of a long list. I need to sort of I can have a little bit more look at it. I'm not sure what's happened with that echo, but Sandra, do you want to come in now? And then I'll see if Anne wants to speak.
Thanks, Mark. I think Councillor Selman had her hand up.
Oh, did she? I see your comment here. Councillor Selman?
To clarify if
there's lots of, I think, interference. I think, Malcolm, I think you're cutting in with quite a lot of background sound. I think you've just been muted. Caroline, do you want to start again? Now we can hear you properly.
Yeah, I'm sure it is, but there's the reference to a representative with poverty in their portfolio and violence reduction in their portfolio. Just clarify that's meant to refer to cabinet member. I assume it is, but just checking that that's the case. And then I guess it was not opining an answer to it, but just whether we're sense checking which bit of housing, as it were, needs to be around the table. So I guess if we've got director, neighbourhoods and housing, that tends to often be our housing stock as a landlord as council, which is slightly different than housing strategy and housing needs. So we might just want to think about who the right person is around the table for that.
Okay, Sandra.
Thanks. Actually, that's a really helpful point to finish on, because I wanted to clarify some of the point, actually partly responding to what David said, which is that to remember that this board isn't about making policy for all of these other areas. It's about us working with these other policy areas to drive forward a health policy agenda. So it's the health in all other policies, as opposed to how do we start making health policy, or how do we start making. So what we're not going to be doing is replicating other forums where those people meet together and discuss those things. We'll be discussing, in the way that we're going to a bit later with the transport policy, we'll be discussing their policies through a health lens, if you can discuss something through a lens. But with the health, we'll be looking at it and understanding it from the perspective of how does it improve health, how does it reduce health inequalities, and where are there opportunities to improve the way that it does that, and where it does the opposite, where are there the opportunities to mitigate those impacts, those negative impacts. And that's really what we'll be doing. So I think that the duplication of some of the membership of other boards should be less of a concern, as long as we're clear about what the purpose of this board is. And then, so in response to Councillor Selman's point about housing, it actually is about, it is really somebody who's going to speak about housing strategy and how we use that for the benefit of how we are not just about providing homes and as in shelters, but how do we use our housing strategy in a way that's about promoting health.
Tanja, that's very helpful. I think just with a view to agreeing the membership, we've had lots of suggestions, and I think there's no having to go away and having to think about that balance. I'm not sure whether I suggest that's done outside of the meeting, whether the board will actually still want to have an email exchange so they can see the final suggested membership before it goes to cabinet, because it would be a shame to miss that opportunity to agree it in the October meeting rather than have to wait till January. But nonetheless, we're not going to get to the final list here today. With that, I would hope that would be a reasonable way forward. I'm not seeing any nods or shakes. I think we need to finish this work outside the meeting and send it round. I
think people are nodding. We can undertake to finish that. So we'll take down the suggestions and the clarifications that we've discussed today, including Anne's that she put in the chat. I think she was trying to come in to speak about, but couldn't unmute her microphone. And for those of you who can't see it, it says that the Group Director of Adults and Health should be on the board. And yes, absolutely agree with that. And so we'll take all of that. We'll come up with a revised and more slightly more detailed list that reflects that discussion.
Sure. And it'll be worth just maybe throwing that around with us in our planning group, with the joint chairs and yourselves, and then we'll distribute it. Great. Okay, we better move on now. Thank you. So let's move on actually to the Health in All Policy Strategy paper on transport. So Andrew, did you want to present? You have a slide deck. I'm sure we're going to be, not sure if you're sharing it or... I
will share it there.
Yeah.
I'll just do that now.
Welcome. So we've got about 20 minutes or so for this item. So
hopefully you can all see that now.
Yep.
Yes. Okay, just before I start, I've also got Tyler Linton from my team with me at the meeting this afternoon, and he's my senior manager on the transportation side. So if there are any other questions, he ought to be able to help me answer that. And also, in terms of some of the comments that John Thornburn made, they were really quite a good set of comments covering the whole of the transportation type remit. I would say that with our transport strategy, we will have consulted him, and he would have been one of the consultees as part of developing both the transport strategy and our local implementation plan. And we would be more than happy and would welcome any discussions with Healthwatch going forward. So what I'd like to just cover very briefly this afternoon is do a bit of context and a quick reminder about the connection between transport and health, then go on to talk about the transport strategy and then how we are responding to the COVID-19 emergency. So to start off with, there is a well-known and established connection between public health and the environment and transportation. And in 2014, Transport for London recognised the importance of this and went forward and developed a healthy streets approach, which we use to help to inform our transport strategy, which was approved in 2015. I'm not going to go through each of these, but this sort of tries to summarise some of the impacts. The column on the left talks about a person who is physically active every day and the reduced risks of various diseases that they would have. And then in the middle, it talks about and gives some statistics about how actively or physically active someone is if on various modes of transport. Clearly, car transport being the least, going up to if someone were regularly cycled, and then looking at how the main health packs can be improved. Physical activity clearly does an awful lot, and if you then look at air quality, road traffic collisions, noise, and the ability for people to access various locations and the severance, it has quite a wide range of impacts, potential impacts on health, and this sort of highlights and strengthens the link between them. Similarly, if you actually look at where potential health improvements could be achieved, there's quite a few of these which actually come back and relate to transport. So whether that's walking and cycling at different distances, and it just shows the benefits to health that active travel can achieve, and the importance of actually linking these towards any health strategy and making sure that we are working together in taking them forward. As part of TfL's Healthy Streets strategy, that they've had 10 indicators on what would be part of a healthy street. Again, that's about encouraging people to make use of the streets, encourage them to get out and walk around, use healthy transport, and to feel safe, and also to make sure that the environment that they are moving around in is safe and with clean air. The Healthy Streets concept is probably summarised by this slide. I could have shown an indication of one of our schemes that we've indicated an improvement scheme where you can look at the scores on the Healthy Streets before we go in there, and then what we've done to try and make it a lot more pedestrian friendly, cycle friendly, reduce the dominance of the motor vehicle. And rather than that, I've shown what is this illustrative version where there is very little private transport within the area. There is some servicing by deliveries, there's public transport, roads are easy to cross, there's lots of trees and open space, so the air quality is going to be good, and it's a nice safe environment to for people to move around in, and with less traffic in the area, the air quality is likely to be a lot better. The council have developed a transport strategy, and that covers the period 2015 to 2025. Its aims to deliver a coherent set of sustainable transport policies, proposed and actions that aim to further improve walking, cycling, public transport conditions and options for all our residents. There are a number of strands within the document, and they cover each of the individual modes of transport, so walking, cycling, public transport, and road safety. So they're all there, and it's a key to actually trying to ensure that the borough is safe, is promoting sustainable transport around, recognising the need for people to move around the borough.
Andy, can I just cut in for a second, because I know you've got a large slide deck, and I know that we're keen for us to explore the key lines of inquiry as whether they fit. We're testing them out on your strategy. So I just want to make sure we have enough time for members and colleagues to feed back to you, as it were. So just a little plea to see how, I think if you went through the whole slide deck, we would run out of time a little.
Okay, I was trying to move through that, and I'll do that quicker then. Okay.
Thank you very much.
So, or contrary to what John Thornburn said, the council does have a movement hierarchy, and pedestrians are at the top of that hierarchy, and car-borne commuters are at the bottom. So that is embedded in the strategy, and it's also used throughout all of the parts of it in looking at the key outputs and targets within it. We've got a fundamental choice within the strategy: is do we want streets for cars, or are we going to have streets for people? And the transport strategy aims to move from a car-dominated one to a pedestrian-friendly and cycle-friendly one for sustainable transport, and that is embedded in some of the mayor's commitments as well. Within the borough, 70% of people do not own a car. 40% of trips in the borough are just through trips, so they're not providing any benefit. And at least and around 30% of residents would cycle once a month. And that shows the importance of not having a motor vehicle dominated public transport. But the slide does talk about the needs for some important equalities considerations. We also have a local implementation plan. This is how the council shows that we are meeting the Mayor of London's transport strategy, and it's got a range of things that we are aiming to do within this plan, and this tends to be more associated with just rather than just policies. It's actually got a range of schemes to deliver, and these are things like school streets, pocket parks, cycling, electric vehicles, SUDs, and sort of road closures to reduce the dominance of the motor vehicle. Transport very clearly has got challenges through the COVID-19. Public transport capacity and ridership is down. We've got problems with TfL's got problems on the financial crisis, and that also affects the council in that we no longer are getting funding through the local implementation plan, albeit we are getting some funding for other measures. There is a urgent need for providing space for social distancing on the street, and there's a great risk is that if we have a car-based recovery, that there will be further issues on the public realm, including safety, public health in terms of if people are going back to using a car, it's reduced physical activity, and it also has impacts on the environment. And in general, if it's a car-based one, it's very contradicting our current strategy. This is to show the risk that we do have with a car-based recovery, in that it shows the car usage compared to pre-COVID levels, and even at a point in August, before schools were going back, some of the car and transport levels are at or above what they were before COVID came along, and that's still with a lot of people working from home. And so there is a large risk that if that continues, we would be in a situation with more cars causing health and transport problems within the borough. There's been an assessment by TfL about what the potential increase in car usage is if we go back to being a private transport orientated community, and this shows that Hackney has the potential of having a greater shift to use of cars, because at the moment we've got low car ownership, but most people leave those at home during the day. This is the same slide as I've shown previously, but it indicates it's got the addition for cycle usage on top. And what this shows is that there is a huge potential for people to cycle. So when COVID was here, the level of cycling went up 4 times. And that just shows that there is the capacity for more people to shift over to cycling. Again, it comes down to a choice about where we're going to move. Are we going to shift to a car-based return, or are we going to look to move some of the unused road space during COVID to give it over to more people? And the Department of Transport are encouraging, NTF are encouraging boroughs to make a change to ensure that the recovery from COVID isn't a car-dominated one, but is a public transport and sustainable transport-based one. We're moving forward with an emergency transport plan, and that should be going to Cabinet in later this month. And that is about rebuilding a greener Hackney, and that is to ensure that we are not going down to the car-based programme. We have responded to the DFT and TfL's requests to ensure that it's not a car-based one by putting in bids to take forward a number of schemes, and that has resulted in funding to expand the school streets programme, and we've got funding to do 40 additional school street sites, implementing low traffic neighbourhoods, bringing forward cycle routes, bidding for cycle training and support packages, looking to extend cycle parking, but also looking at a wider traffic reduction across the borough to deal with this 40% of traffic that is just through traffic. There's a couple more pictures of what we have been doing. Looking at the next steps, I think the first thing we would look to try and work with this board is seeking approval and support of measures that we are taking forward at the moment to continue the support for the 70% of residents who don't have a car, and ensuring that we can continue to improve the air quality and their sustainable transport activities, seeking health protection, looking to try and ensure that health practitioners can support this by signposting services, for example, signposting people to cycle training, to where cycle routes are, and public supporting schemes with the help of messaging around the benefits. It's trying to maximise opportunities afforded within the new DFT active travel guidance, and it's just working together to identify areas with the highest health needs. Okay, I've sped up a bit, but that's the end of my presentation, Chair.
Andy, thank you very much. That's great. So can you take this presentation down now, and then we'll get back to everyone's faces. Thank you. Do I have any hands or requests to speak? Chris Kennedy.
Quick question. If people all revert to their cars, Hackney in that London map, we look like we had the worst increase in car usage, and that's still with 70% of our population not owning cars. I mean, that seems really. I don't quite understand with such a relatively low car ownership how we can have that would have such a huge effect on us.
I think it's because at the moment the people who have cars, they generally don't tend to. There's not a high level of people who use them during the day, so they will use public transport. They'll cycle to work or whatever. They have got a car. It's just not they use that much. If all of those people, or a high level of those people, decide to start making all their trips by car, the change from where we are at the moment is quite significant. Further out of London, a lot of people tend to use their car already for trips. So it's because we've got such a high level of sustainable transport use at the moment.
Can I make a comment in terms of the key lines of inquiry? Around the real and perceived risks. They're not the same of contracting COVID on public transport. I mean, that's what a lot of people say they're worried about. That's what's driving them into their cars. So actually, in terms of looking at those 6, what could or should be done to maximise the positive health impacts of this strategy? Well, clearly what you're saying is, trying to minimise car usage is clearly a good thing. I guess how do we help the communication that it's safe to use other transports? As I say, an actual and perceived risk, particularly when you see people who aren't socially distancing or aren't wearing masks as much as we would hope they would when they're in confined spaces.
I think there is a big issue to overcome, because right at the start, the message from the government was not to use public transport, and from TfL, there is a big issue now to try and stress that public transport is safe. There is an issue ongoing, and Councillor Burke is going to be writing to the Commissioner for London for Transport about how we can try and encourage and ensure that more people who are on the public transport are wearing the masks, because that is a concern that people see and therefore are discouraged from doing it. There are also issues, and again, sort of John mentioned it, about lack of public transport capacity, particularly with a lot of buses at the moment being for school children only, and they're still not operating a full bus service. So there are a number of things that need to be done to, one, increase capacity, try and change people's views that it is safe to use, but also for people who are using it, try, where it's appropriate, try and have some level of encouragement, enforcement to wear masks.
That's clearly a bigger piece of work, isn't it, in terms of that communications. Any other thoughts?
Probably needs to be done regional wide as much as through Hackney or the Health Trust.
Well, yes, but I guess we can all do our bit to try and encourage this. Talking about what we can do as a board to help support this policy.
Chair.
Yes, Phil.
Sorry. I think there were some really good, very public letters from acute hospital trusts about 2 months ago around supporting sustainable transport for the health benefits, and also to promote, I think, key workers and people being able to get to work in a safe way. So without using cars, and at that point, obviously, concerns that we've just talked about around public transport. I still feel, for all of the discussions I've had at a NEL level and beyond about recognising the impact of air pollution and non-active travel lifestyles, there isn't enough support from the health system for these changes. They are very difficult, they're not easy. I know they can impact on individual GP practices and how they operate, and also parts of the social care system around visits and things like that. But I think that sense that we're all working together towards something is incredibly important, I think, while still saying there are opportunities for people to debate and shape the rollout locally of schemes. And it's really important that that GP practices are a key stakeholder in a low traffic neighbourhood. They know how the grain of some of that. But I think those messages coming very strongly, and they've been repeated from the hospital trust, have been really useful at certainly mitigating some of those people that keep on using emergency ambulances and police and fire access as reasons not to do this type of work, and alleging that it's going to have a negative impact on people when they need to access public services.
Yeah, that's very helpful. I mean, it's very interesting, isn't it? Because the figures for the number of people who have died with COVID-19 related illness are described every day, but the number of people for whom air pollution has contributed to their death is not. It just becomes a more distant thing. Okay, I can't see any more hands up. Andy, thank you very much for that. It's really impressive policy, and I'm sorry I had to speed you on a bit quicker than you ideally wanted to, because there's a really rich day presentation. So thank you for that.
Thank you.
So I'll move us on to item, where are we? Item 11, the pledge to reduce ethnic inequalities in mental health services. Rhiannon, I can see you there, leaning against the grey cushion. Are you presenting this, and would you like to introduce your co-speakers? We've only got about 10 minutes or so on this item. I know that you're hoping to the Health and Wellbeing Board to endorse this pledge.
Yes, I am. Thank you very much. My co-speakers, unfortunately, Solomon and Sakib, are having to go to another meeting. We were expecting to be a bit earlier on the agenda. So Fozia and I will present. I am Rhiannon England. I'm the clinical lead for mental health at the CCG. We did have Solomon, who is a local authority working with the Young Black Men's work, and Sakib, who's HCVS, but I said I'd read their slides out, and Fozia is from the CCG. So
Rhiannon, what's your role, just to remind us?
My role in this is I'm the clinical lead for mental health at the CCG, and to declare I am a board member on Synergy, unpaid in brackets, just to be clear. Okay, so can I have the first slide, please? So this just is introducing what Synergy is about. And as it says, it's a collaborative national initiative looking at reducing inequality in mental health for people from BME backgrounds. And as we know, the inequality within mental health is a real issue, and so is the overrepresentation of certain BME groups within severe mental illness. So it's really important that this work gets prominence, and that's what Synergy have been trying to do. Next slide, please. So what they've done so far is quite a lot of academic work nationally, and producing a lot of really interesting papers and working with different communities. And then they have decided, or we have decided, to have a national pledge and to try and get more into local authorities and CCGs to talk about how systems are going to change. And so what this slide shows is the asks that we would sign, so the pledge that we would sign. I'll come back to that at the end, though, and perhaps go on to the next slide. And this was what Solomon and Sakib would have been presenting, the work that's happening in the local authority through the Young Black Men mental health strand. And they as within their work, came up with 3 objectives: access for young people, to reduce the fear and suspicion of certain groups for orthodox mental health services, and to look at wider policy decisions. And that work is well underway, and there's lots of interesting stuff coming from it. Next slide, please. And so talk about improving access or outcomes for young Black men. I think they're going to change it to young Black people, actually, because I was a bit concerned about the leaving women out of this. And I think what they are seeking, or what we are seeking to do together as a system, is really seek accountable change. So there's going to be an accountability board which will hold both us as local authority and CCG commissioners of service to really change the nature of the services as experienced by BME groups locally. And so I'm looking forward to being taken to task by the accountability group. Also, there's work within the CCG. So next slide, please. And Fozia is going to talk about the next couple of slides, and then we'll come back to the pledge.
Thanks, Rhiannon. So I just wanted to touch on the other work that's happening system-wide. So the Equality and Diversity Group, which is system-wide, is also working to embed quality-based decision-making across the system. So this, at the present time, we're looking at co-producing equality impact assessment tool and guidance, identifying senior champion within the system to embed in quality-based thinking, developing and delivering training as well. So there's a number of things that are happening within that group. Can we just move on to the next slide? Yeah, so I've touched on the work that's been happening with the Equality and Diversity Group. Can you move on to the last slide?
Okay, so this is what we're asking to pledge, and we're asking your support so that we can do a system pledge. The rest of the documents about synergy show what other areas in the UK have done and who's pledged that they will support this. So we're basically asking to not just as a tokenistic thing to make a pledge, but actually to do a lot of leading of this work. And we have been doing that already. Sonia is well versed with the synergy asks and has been in contact. We've done stuff for them. So there's a lot of communication that's already happened. And I think it's obviously a really, really important issue for us locally. So we would ask that you would support us pledging as a system for this change.
Great, thank you, Rhiannon. Sorry, had you finished?
Yep.
Yep, good, okay. I've got a question from Philip Glanville, and then I can see you, Antoinette. I've got you there.
Can I thank Fawzia and Rhiannon for presenting the work, and I know that your co-presenters would have wanted to be here. I really welcome point 7, the biannual progress update, as part of this statement, but just wanted to probe it. If we're signing up as Health Wellbeing Board, will we get that biannual progress update here? Or if not, where will it go, so that we're making sure? I think Hackney's got a really good track record within the council of only signing up to things that it will do and then sort of report back on. And I think that's really, really important. The other thing we're doing, and Councillor Williams has been working this through with part of the Sonia team, is just defining BAME and making sure that we don't use it as an easy shorthand, and recognising the differential impacts within. And clearly, Young Black Men's Project is a clear example of that. The mental health outcomes, the other outcomes, and I can see Deputy Mayor Bramble nodding. I'm sure she'll jump in off the back of this. You know, that is a dedicated piece of work that looks at the impact on a specific community while recognising it's valuable to place equality and diversity at everything we do. So those are my 2 really good points, clear points, sorry, and really welcome this, and it's such a good bit of work.
Yeah, here. Councillor Bramble.
Thank you, Chair, and just want to echo what a lot of Mayor Glanville had already said. Wanting to thank you both for the presentation and the work that you're doing. I know it's been on a journey, and for example, one of the things that we've always been exploring with our health partners is how we change systems so that we find young Black men, for example, turning up in early screening, going for talk therapy, rather than when they're at the statutory end of the system and are being sectioned, and what do we need to do differently to ensure that we capitulated that. Just to build out a bit on Rhiannon's comment about young Black men and changing it for everyone. I think it's really important to reiterate, when we had this model in place, we absolutely want to ensure that the programme can be adapted for all groups, whether it's women or whether it's other ethnic minorities. But it's really important that we don't dilute the work that we're doing around improving outcomes for young Black men, because it's very rare in society that we focus on young Black men and focus in a positive way to activate systematic change. You know, the theory of change has really developed this piece of work, and I too am really excited about the accountability board, because the young Black men themselves will sit at the top of the pyramid, for example, or the chain of accountability, and be demanding that. And as I said again, we can use it for other groups within our community going forward. But just want to commend you for presenting this and the work that's going on. Thank you, Chair. And just to say, just in case Councillor Kenny doesn't come in, I know that he's done some really good work around this, promoting this and working with Solomon. They've had some really productive engagement pieces. And yeah, it is a shame that Solomon isn't here, because he has been a really good driver of this work, Chair.
I think we should make a specific note of that in the minutes, that we're sorry that the others had to go, and their work was acknowledged. The importance of their work was acknowledged at the meeting. I've got John. Actually, I'm going to probably take this as the last question list. Anybody's bursting to say something else. So, John Williams.
Thanks. Yeah, an excellent initiative. I'm fully supportive. I'm really pleased about it, and I'm also very pleased about the work that's been done around the equality impact assessments that kind of we want to push along as well. So it's an excellent piece of work. Just a kind of couple of comments on the last slide, number 3, working in partnership with BAME community service users and relevant community agencies. I'm kind of conscious of local conversations about the use of the term BAME and the desire to use the term diverse communities, and wonder if that's a better term here, given what the local community has been saying about the use of BAME and the way they find that really a reductive way of looking at them. And I'm also a bit concerned about why the term service users is used. Why can't we use the term people? Again, you're reducing people down to their services rather than seeing them in a round. Thanks.
I'd be totally happy to change that for 3 and take everyone's advice on that. Yes, I'm totally fine about that, and we can certainly change that.
Thank you.
Dave, did you want to come in quickly?
Well, I just echo. I mean, obviously, I've discussed this with Rhiannon. I mean, I guess it would just be helpful just to be clear about the emphasis on symptoms in the pledge itself, and what our understanding of why that is emphasised in that way, and clinically what we might be asking our clinical partners to think or do differently.
Thank you.
Sorry, I didn't quite understand that. Was that the difference in diagnoses and symptomatology you were talking about?
Well, just in the 3rd paragraph of the pledge, it has symptoms of psychosis and some symptoms, and I just wondered what your understanding of that was.
Well, I think the sort of academic research over the years has been very well. There's been an awful lot talked about symptomatology. What does that mean in terms of diagnosis for different BME groups? And I think that the academics are still, and the departments of psychiatry nationally, there's lots of contradiction about it. And I think it's a bit, for me as a GP, it's a bit of a minefield. And I think that we need to be constantly looking at people's narratives and a sort of narrative approach rather than a diagnostic labeling type approach. But that's my prejudice and my view. There are an awful lot of different views on this nationally, and have been forever. So I haven't got a good answer for that one, but I have a personal view. That's about all I can say.
Okay, I'm going to move us on, David. It's really important because time is pressing. Just with a view that the board's asked to support this pledge, it sounds like that's a pretty easy one to put to us because everyone's comments are so universally supportive. If you could just take the slide deck down so we can see everyone's faces, so we endorse it. Can I just see some thumbs and nods? Chris Kennedy it takes the award for the most obvious nodder. Thank you, but I can see others too. So thank you very much, Brandon. Thank you, and thank you for colleagues. And again, pass on our thanks to those who couldn't be here to present this really good work. So I'm going to move us swiftly on to
Thank you.
You're welcome. Anne Canning, you've got a 5-minute or a bit less little verbal update on the development of the partnership-wide Children and Families Plan.
Thank you very much. And I'm sorry about my microphone earlier. I have no idea what happened. Little short note on page 53. I probably just wanted to get an early feel from the board about a proposal from Children and Families that as a result of the Ofsted inspection with the areas for improvement, we've set up internally 2 boards, one that's officers and one that's members. And as we're going through the work, we always had this plan that the quality of support and services and ambitions we have for our young people can't be delivered just by us. It's delivered by all our partners, whether the community, voluntary sector, health, police, and I'm sure I've offended by leaving some groups out. And we're about or going to hope to embark on a piece of work to get a plan articulated across our partners about what we think is the type of quality delivery and experience we want children and young people in Hackney to know that they've got an entitlement to. And it's not that the policy that will, or the partnership plan that we'll come up with will drive intimately what happens in the individual services, but it should sit above individual partners, but it should sit above them, so it acts as a kind of guide that when you're developing what is perhaps your own local internal health plan, you know that what's been agreed centrally is what would be best practice for our children and young people. One of the little difficulties we have is trying to get a governance route for it, which is a partnership governance route, without setting up another partnership board and another stream of governance. And so the proposal is that there is a subgroup of the Health and Wellbeing Board, which ideally has all the partners on it represented, that actually the Children and Families Partnership Plan reports into, both for its endorsement of when it's written, for its, that it is what the partners want it to be, for what the actual plan's quality is, but actually then that group hold partners to a plan that we're delivering it and we're effective in our implementation. So it's just a marker down. Does that seem a sense? I hope that seems a sensible route forward, and I hope that you as members of the board appreciate the importance of this work, and a subset of you and the fuller board, when you agree its membership, would be happy to show some governance of this plan, which has to be a partnership plan. So
Thank you, Anna.
Thank you.
Good. Okay, I can see no hands. I'm not spending too long waiting for hands to go up. I think therefore I will take that as an acceptance of support for this direction of travel, Anne.
Thank you very much.
You're very welcome. And a few nods to go as well. Thank you. So, John, turning to you for our penultimate piece, we have a few minutes to talk about the extension of the Hackney Health and Care Complaints Charter. John Williams, where are you? There you are.
Sorry, I suddenly disappeared. I managed to kind of drop myself out of the meeting. Back again. Okay, thank you. I was going to do this jointly with Malcolm, but he's having some troubles joining, so I shall push ahead. Okay, this is basically this is about the Health and Care Complaints Charter that we've signed last year. And it's about extending it and reviewing it, and it's really for noting today. Really, just to say that the charter's been operating since over the last year, and we want to just have a look about how it's going. So it's really about kind of going to the current signatories and asking them about, there's a number of lists, and I won't go through them because of time, but it's on page 56, you can see the review of the charter and the 4 bullet points that we will go to the existing signatories on to ask them how is it going. And we want to kind of bring this back to the November meeting, so Malcolm will be writing to all the existing partners and with those questions, and we look forward to their responses. I think the more challenging area is the extending of the charter. We'd like to thank GP Confederation for helping us shape a charter for the GPs who are currently not signatories to the charter, and we think a kind of a big missing point part of the charter as well. We have had some engagement with the local medical committee. On a couple of occasions, we've sent them the charter that we worked out with the GP Confederation, and we haven't had a formal response. We do understand that they have some anxieties about it, but we'd like them to do a conversation with them about that, because they apparently think it's going to confuse patients. We don't think that's the case, so we think it'll help patients. I think the entire point there is this will help patients and people who use services to better navigate the complaint system. That's the point of it. But then we also want to kind of move it forward into kind of extend it to other areas like dentists and opticians. I think that's essentially, this is really for noting about what we're planning to do, and that we will bring it back to the next meeting. Happy to take questions if they're needed.
Thank you, John. One thing, it's interesting that in fact, the GP Confederation are coordinating on with supported by the CCG is the use of a care opinion with practices, so that before issues become to the level of complaining, that people can actually feed back information, have a two-way dialogue. And I know 10, 12 practices are engaged in a sort of ongoing pilot of that, and that's produced a lot of really interesting work. So I'm sure if you're working with the Confederation, they'll be sharing that approach and how that could be incorporated into the thinking. So I know
the Confederation will kindly share us a free license to care opinion, so we use care opinion, and I'm grateful to Confederation for sharing that. And yes, it is useful. It is very useful, and they have been sharing data with us. So yeah, it's good.
Okay. All right. Well, thank you for that update. And we'll wait with interest to see how you get on with the LMC and practices and opticians and a general report about usage, etc., and feedback. So thank you for that, John.
Thank you.
Good. I can't see any other comments in the chat or hands, so I'll move us on quickly to back to you, Sandra. A reflective space about our approach to collaborating and thinking about how the board can operate more optimally to adopt health in all policies approach. So a quick verbal piece to reflect on some of those elements of the work we've done today, I guess.
Thanks, Mark. Really, it was for us all to reflect as a board. I'm not really sure why it was put with my name, but I'm quite happy to help people to frame it, and to help people to think about a framework in which to reflect. And so, we could just reflect about how we're working as a group, and it's a perfectly legitimate, of course, for us to think about whether this board is actually functioning better and is on, and if this journey is going in the right direction compared to where we were when I started, because we're still in development. But in terms of the health in all policies, developing that framework and having these conversations, having that presentation about the travel strategy, and trying to start to look at that using those key lines of inquiry. This is an opportunity really for us to think about, did that work, and what could we have done differently, and what could we do better next time, and what you would like to see. And if not, and if you don't have a particular reflection, excuse me, if you don't have a particular reflection for today, I'm really sorry, I've just been talking since about 8 in the morning. If you don't have a particular reflection for today, it's just to help to prompt you to think about it, and that you might either want to feed it into the chair or bring it back next time. And I might have to stop now.
Yes, you've talked yourself out, absolutely, literally, Sandra. So I think you should. We understand what you're saying. So, can I ask board members and guests, indeed, any reflections they want to share from in the way that Sandra's constructed it like that, particularly around this health and ill policy work that we're trying to develop? Councillor Kennedy, yes.
Thanks, Sandra. Yeah, that's what happens, Sandra, when you present the same slide deck 10 times in a day. I just wanted to reflect. Some of us have been having conversations, and of course, many of us sit on the Integrated Commissioning Board. The Integrated Commissioning Board is considering quite a large system change at the moment, and this board, our board, the Health and Wellbeing Board, is cropping up on organisation matrices and how we fit in. On what we discuss and what priorities we set for ourselves as a much broader health system are going to interact in new and different ways as the health system changes. So I think we have to probably always keep this slot for a while because we are in a state of flux and change. But in answer to Sandra's, fundamental question, are we going in the right direction since she arrived? Absolutely, we are. And I know it was one of your priorities when you arrived as Director of Public Health to make sure this became a much better functioning and higher functioning body. And I think Phil has shared that ambition as well. And this is definitely in a much better place than it was when certainly I first came to one of these meetings. But absolutely not there yet. And we need to keep thinking about where we fit in the system.
Chris, that's really helpful. I absolutely agree with what you said. Other thoughts? Phil, I can see a hand. You're slightly small on the screen because you're a little away from the camera.
Oh yeah, my weird bunker. I really do. I think Councillor Kennedy is absolutely right. The slot's really good. I think the interaction and focus from across the council and seeing this is the place to be and have some of these discussions and some system leadership is really important. I also, reflect on we've achieved quite a lot without going to consultants and having away days and round tables and things like that. And I think it shows you what you can achieve when you start injecting that kind of clear sense of where we want to go. And I thank all of those because I think it is Sandra's sort of new thinking that's helped, but I think we've all played a part in that and a willingness to play a part in that. My two sort of slight things I think we need to think about is effectively I think we've created two sub-boards of the Health and Wellbeing Board today, and we've added new people. So I do think we need some mapping. We need to think about how the world externally views this, because if you Google this body and its associated documentation, there's a huge legacy of where we've been and not where we are at the moment. And that just requires a bit of a sort of pause and reflect and some work from Sandra's team to just get that in the right sort of place, I should think, so people can think about interacting with us and seeing what we're doing. They won't just do that through the council's governance sort of function, portal, whatever you want to call it. And the last bit is in terms of impact, is what we're measuring, and down the line, the sort of how we want to present data and the things that we're focusing on. It's clearly not just a data-driven exercise, and we're not there to look at dashboards, but I think there are things we want to see, and where we also hold the policies we've agreed, because effectively we've just signed up to something, and I've made sure we've done that publicly because I've tweeted. But we will sign up to things, we will agree things, and we need to make sure we've got a sort of depository for that kind of piece of work, I think.
Great. Councillor Bramble.
Thank you, Chair. Just to say, thank you for the direction of Dr. Husbands, and as the Mayor Glanville said, everyone around the table, or the virtual table, so to speak, in terms of the transformation. I think this shows the potential, even though there's been changes to what health and wellbeing boards can and can't do, that actually, if you have a good structure in place, there's potential to really make a difference within the community. I think one important thing is that we need to still think about our priority groups when we're bringing papers and any item here and what that means and how that connects back. I think what's really good is that we always have a resident voice, but it's really listening to the resident voice and maybe checking back, what residents saying to us in line with our priorities, and do we need to rethink them and incorporate the priorities when we're hearing from the public? But those are my quick comments, but just want to commend the work that we're doing here and the potential that this has. Thank you, Chair.
You're welcome. Hear, hear. Raj, got a comment from you.
Hi, yeah, thank you, Dr. Sandra. That was really good. I just want to make a point that very important to think about the person that we are serving and helping out. So thinking about how do you put that person in the middle and how we wrap our services around that person in terms of supporting, whether it's housing need, whether it's the health needs, social care needs, whatever that needs be. And it's important to make sure we encompass all that. And we're all working collaboratively right the way through to make a real difference at the end of the day. And that's important. We don't lose sight of that, because very often we do a lot of things in silos, but not realizing the most important person is the person you're serving and how you wrap services around them. And it's important to get all the service providers and everybody that's helping them support that. That would be a good idea to make sure that we encompass this in terms of our going forward. And I think that would be a good way forward. Those are my thoughts.
Thank you, Raj. And I think probably a very good note to end on this discussion. Thank you very much. So I'll just finish off because we are aiming to finish by 6. Date of next meeting is the 11th of November. Is there any AOB that somebody needs to quickly bring to our attention, which is pressing and needs our attention right now? No. In that case, I shall wish you good evening. Wish everyone else who've been watching us will watch us in the future good evenings, or whatever whatever time of the day they might be watching us. I wish them well. So cheerio, everyone. Bye-bye.
Thanks, Mark.
Good evening. Thank you, Chair. Bye-bye.
Bye.